So we're starting part 2 of interviewing Dr. Mowrer. We were in the thick of talking about assessment, so I'm going to just keep rolling with that.
Sounds good.
This is fun because I think we're getting into some of the more specific and interesting questions from students, and I have to say you guys came up with some really, really good questions, like some that I wouldn't even think of.
I think I sent you a text yesterday that was like, wow, these questions are
good.
Impressive.
Yeah. So this one I really liked. There's a question from a student that said, are there any situations where your available tools cannot answer a specific question? And then how do you handle that?
Mm-hmm. Yes, is the answer.
Yes.
So unfortunately, we can't answer every question. And when I read this, there were 2 things that came to mind. Some referrals that I've had that I unfortunately had to kind of discuss with the team about how I can't absolutely verify. One was someone who had schizophrenia, but they were also curious whether there was an autism spectrum to this individual. Now this individual was a much older adult at this point, and unfortunately we had no access to records, so understanding what their development looked like. There was no family members that could provide us any information, and so and you may know this or you may learn this, that actually there's a lot of overlap between some autism spectrum symptoms and symptoms of schizophrenia. And
haven't quite gotten there yet.
Yes.
But yeah, in
So
terms of just how people look interpersonally and
Right.
social skills deficits and
Exactly. And so unfortunately, because we don't have tests that say yes, this is absolutely schizophrenia, or yes, this is absolutely autism spectrum.
Right.
I couldn't answer that question for them because I didn't have additional data that I needed outside of the tests. The other question that kind of similar was intellectual disability. So we have a lot of tests that will measure current cognitive functioning. However, to diagnose an intellectual disability, these deficits had to be present during their childhood and adolescence. And so if I don't have data that clearly can say that was going on, that can sometimes get in the way of us clearly making a diagnosis. Because another thing that you may learn is that individuals with schizophrenia will also have cognitive deficits as well. So their scores on tests may look in that kind of deficit.
And those deficits, could absolutely be because of the schizophrenia, and then like both can be true.
Right.
And it's very sticky.
Yes.
And hard to differentiate.
Exactly.
Yeah. Thank you. You sort of answered this next question, but it was about like easiest versus most difficult kind of conditions to assess. So it seems like there's a lot where, with schizophrenia and the, cognitive deficits that can get difficult to pinpoint if they are due to schizophrenia versus some other co-occurring condition. Right. Would you put that in the more difficult box?
I would, for the most part.
And not always. Like, you have really amazing records on people.
That's the key. That if you are lucky enough, and it's not usually the case.
Probably a younger person. I think like now, some of these, if you're sort of like starting now, we probably can do a lot. We can do much better. I was saying to my students, like autism spectrum, for example, wasn't recognized or assessed for. I mean, even when I was a kid.
Exactly.
When you were a kid.
Yes.
So that's a much newer thing that now we have much better, data on, and same is true for learning disorders and all kinds of things that we're assessing for in schools that we didn't used to. So probably for your younger patients, it's gotten better.
And I think kind of going off of what the most difficult testing cases are, it's those comorbid. So when someone has more than one disorder, which is
a lot of people.
Yes.
Like probably at least half, right?
Right. And especially the vast majority of our patients in our hospital have a trauma history and also addiction that goes hand in hand, and then active symptoms related to that in addition to a major mental illness like schizophrenia, bipolar disorder. And so trying to disentangle all of that. And some people also have personality disorders. So that's where things get really complex, is that trying to, oftentimes we can't just compartmentalize and say,
Yeah.
this is all just schizophrenia.
So on the flip side then, for that question, would you say that the easiest would be the people who, like the rare people who do not have comorbidities, who have like major depressive disorder? And if that's all that there is, that's pretty easy to figure out.
Or current cognitive functioning. That's
Yes.
probably one of the easiest things for me to...
I can tell you how this person is functioning right now.
Yes, that's an easy question for me to answer.
Whether or not it's because of XYZ, not so much, but what is their functioning? You can do that pretty quickly and easily. Okay. I know a lot of students were interested in, and I know that I've always been fascinated by this as well, as have you, just how do you know you're getting good, accurate, truthful information? And along those lines, isn't it possible for our really, savvy, smart, snaky people to con us and lie? So like, how do you account for that in assessment?
Right. So, you're never going to be 100% sure that someone is putting in 100% effort or motivation, or are they trying to manipulate or trick you in some ways. And something you always have to keep in mind is things that you look out for. And there are some things in our testing that allow us to look and see if people are putting forth effort or if they're answering a certain way. So, for example, in many of our emotional and personality tests, there's validity scales. So whether someone's trying to look really, really good or trying to look bad.
Right, just to pick up on that.
Yes, if they're responding inconsistently. So if you're having someone just kind of mark whatever.
Like they're making designs
Exactly.
on the self-report.
That'll pick that up. And so we have those kind of validity indicators. There are often effort tests on cognitive measures as well. So providing things that may look difficult but are actually fairly easy, and seeing how they do on there.
People are really giving the best of their ability.
Yeah. The other thing I look at is consistency. So are you finding the same thing kind of over and over with regard to certain cognitive functioning, things like that? Are you is what they're telling you consistent with other people's observations of them and consistent with records kind of throughout their life as well? That will help me better understand.
Kind of put it all together.
Yeah,
like the whole picture.
Is this a pattern?
And that was one of the things, I don't think we've said so explicitly yet, but I have said to my students, and just kind of by nature of your sharing, you've said, right, we don't ever hang our hat on one piece of information, on one test.
Right.
That's why these can be so difficult, right? And you're using an average of at least like 4 tools, but you're also using interview and records and collateral data and observation, and trying to put all of this together to figure out what's going on. So when you were saying consistency, that made me think of like, so a red flag for you might be if someone's reading comprehension was like in the 90th percentile one day, and then on a different test, though it's the same, measuring the same thing, it's 20%.
Right.
And then one, you give them something to sign and they seem to answer all the questions, and then another day you give them something and it's like they've never seen words before. Those would be red flags for you.
That would make me very curious.
And it wouldn't be a typical pattern for someone who has those kinds of deficits.
Exactly. So what else is going on?
What could explain it?
Yeah.
Right.
That
So
would be my question.
that kind of leads into questions about feigning. Yeah. So like, what are some of you talked about validity scales, right? Which I remember when I first had training in those tools, like, MMPI, like that's so incredible that not only do we have our clinical skills, which can fail us, but we have other, kind of standardized, valid, and reliable ways of picking up on some of this. So
exactly.
what are some of the tools that you use to determine if that's a factor?
Sure. So to determine if feigning is a factor.
Yeah.
So not only do we have those validity scales, like you were saying, but there are specific measures out there that do assess for, they call them effort tests, because we then, as psychologists, have to figure out what the reason is for not putting forth effort. So sometimes it's because they're malingering, so faking symptoms for some kind of external gain. Other times it may be that they're just not really interested in the test. They don't care. they're bored, right? There's lots of reasons why we don't put effort in things, right? Sometimes we don't put effort into things.
People can also try to hide their symptoms,
Exactly.
right? So it's not, I think that there's like an external believer that we're probably seeing a lot more people who are just feigning mental illness, but it can also, you know, go the other direction where
Right.
people don't want to be perceived, right, as having mental illness.
And I had a testing case just recently where that was the case, because mental illness is so stigmatizing. And this was an individual who had a really good career, a lot of successes, and then had the onset of a severe mental illness, and all of that was taken away.
Right. So for them, good reason to not want to.
So there was a lot of kind of psychological reasons why they wanted to say, but I'm good, I don't have a mental illness, everything's fine. So.
And are there any, so you talked about like inconsistencies, those specific tools. Are there any observational cues for you that you use in determining if someone
Right.
might be, you know, feigning it for any reason? Because the reason is the part that you have to figure out then.
Absolutely. I think that kind of goes in with consistency as well. So what are they like? I have the benefit of being in a 24-hour hospital.
Yeah.
And so what are they like when they're not with me? What are they like when they're with me? And is this someone who's, you know, hearing voices, so responding to internal stimuli, talking to themselves? Are they doing it the whole time? Is it all of a sudden they can have?
Does it happen when you come on the unit?
Right. And then are they doing it and then they can have a coherent, meaningful conversation with me for 45 minutes? Those are red flags.
And then it starts again.
And then it starts
right.
again.
Yeah.
Right. So and then are they? Do they have coping skills to manage these symptoms? You know, so you start asking some of these questions. Are they endorsing symptoms that actually aren't symptoms related to these major mental illnesses based on what we know about psychotic disorders or other disorders as well? So these are all things that if there's some flags, then I might start digging deeper and trying to figure out what the source of it is.
Yeah. Perfect. So there was a question, two questions, but the first one, it might be like asking you to choose a favorite for a child.
Yes.
But do you have a favorite tool?
Favorite,
measure or category?
Right. No, when I read this, I was like, this is by far the hardest question. Because there's so many, but there were two, so I limited it to two that came to mind. It took a lot of work. And they're both cognitive measures, actually. One is called the DCEF, so the Dulles-Kaplan Executive Functioning Scale. It's kind of there's a lot of different scales within that tool box, but I really think that it does a nice job of honing in on specific deficit areas. A lot of times people will think that someone has memory issues, and it's actually an executive functioning problem, which is actually very common in schizophrenia. And this also, this test really helps lay out the areas of the brain in which these particular functions hit as well.
Cool.
So it's really nice for that. The other one that I enjoy is called the California Verbal Learning Test. It's in the 3rd edition, the CVLT, and it's a word list memory, learning and memory test. But what I really like about it and what I find really valuable is that not only does it say, does someone have a memory problem or can they learn, but it tells you how. So is this someone who remembers, learns things at the front of the list or at the bottom of the list, or they don't really have a strategy for learning? Are they grouping things together?
Right.
In categories, and that, and also are they remembering things in categories, and do they have strategies for that?
Yeah.
And that can really help with this population for recommendations of okay, if someone's going to remember the things at the end, like make things short, and make sure you have them repeated, you kind of have that information. So
that's really neat, because I imagine, this is really true for all of us, not just, individuals with mental illness who are serving, but if someone asks you, like, how you best understand information, you might be hard-pressed to give that, or a lot of times we're actually wrong in our assessment of ourselves. And so it's kind of neat to have this tool that can give you that information.
Yes.
I love it. You did a very nice job with
Thanks.
that. I was worried.
It's tough.
Okay, when you provide a diagnosis, so like if the question is about, you know, clarifying diagnosis or differential, how confident are you in making that diagnosis?
It depends. The classic
That's
psychology
that is the
answer.
psychologist answer to everything. If you're not sure, just say it depends.
So this is why we use multiple sources of information. So if I have, this happens sometimes, when all the stars align, and every test kind of is coming up with the same pattern, the same diagnosis, and then the collateral information, the records, the way we're seeing everything is lining up, then I'm very confident. And I feel very confident. But that's not often the case. It can get murky. And so when I do diagnoses, I do the best I can with what I have. And I'll talk about why I chose this diagnosis, how they meet criteria for that diagnosis, and what I considered and why I ultimately didn't.
So you sort of speak to your confidence in the report, right? Kind of, hey, everything is pointing this way versus, this one is less clear. This is how we're leaning based on the results. And if new information emerged, this could change.
Exactly.
Right? Or if this person's, presentation changed, or right.
And we know that
their functioning, or became more stable, or their psychotic symptoms dissipated more, or whatever.
And we do know that severe mental illness changes throughout the lifeline or lifetime, right? So if we're seeing someone earlier on, are we missing some things that are more prodromal?
Right.
As well. So I just try and caveat it and be as honest and transparent as possible.
So have you ever been wrong?
I'm sure I have. I was trying to think of a specific case, and one doesn't stick out, but I'm sure I've been wrong.
Yeah. I think that's sort of the nature of this, but I draw a lot of comparisons when I'm teaching to psychological health and medical somatic health, because I don't think they are so different at all, right? We often talk about them in very fragmented ways, but it's really typical, right, for our medical doctors to arrive at a diagnosis and then information changes, or it turns out that was wrong because, we all kind of have our lens. I think about that a lot, right? If you go to a rheumatologist, they're looking for a rheumatologic syndrome. If you go to a neurologist, they're looking for a neurologic explanation.
Right.
And they're considering that it might not be that, but you're just more likely to see that, just like we're more likely to use that, psychological lens.
Right.
So, which is why I think getting experiences in different settings, in more, medically based settings and other things, has probably served you very well and kind of expanding that, right? All right. I told my students that you have a preference for assessment over individual therapy. I outed you. And you talked, when you started your master's, about how much you were loving that and loving being a therapist in that setting. So can you talk about the differences and why you think this preference has emerged at this point in your career?
I think what I realized, and it's such a psychologist thing to say, is like how I know what I enjoy is the energy I feel after I do something. So when I started doing both therapy and assessment, the thing that I would notice is that at the end of an assessment, even if it was an 8-hour battery, and that's a lot of work, I would feel energized and excited and like wanting to put the puzzle pieces together. You
come back and start scoring.
Exactly, right away. It gave me energy, it fueled me. Whereas when I finished an 8-hour day of individual therapy, I wanted to go home and pass out. I was just exhausted.
Draining.
Yes, it was very draining for me. Now, were there times where I finished an individual therapy and I had that energy? Sure, but it wasn't the norm. It's much more common that I'm finishing assessments and I'm just having a lot of intrinsic value from it. And I think understanding that for me was huge. So when I was coming to the point of, could I do individual therapy for the rest of my life, the answer was very clearly no. And I think that was kind of experiencing both of them and then seeing, kind of doing a self-awareness and being self-reflective about it was what led me to that conclusion.
And you're someone who, you know, sees the value and recognizes the importance of individual psychotherapy, but also
Absolutely.
recognizes that maybe you're not the best provider of it. And
Exactly.
I think that's a really important kind of skill,
Mhm.
right? For each of us to kind of look at ourselves and say, you know, not just what am I capable or competent, like you're competent, you could do it, but, you know, are you serving people as best as they could be served if you're drained by it? And also, are you serving yourself, right?
Exactly.
Because you have to take care of yourself and be able to give your best, and with
Right.
assessment you feel like you can do that.
Exactly.
Yeah. Can you talk briefly about the difference between individual and group? Because you do co-facilitate group therapy,
Yes.
and seem to enjoy that.
I do enjoy it. I think there's just it's a different dynamic, and it's really, it's fun to kind of navigate a group process, and it's and seeing the group dynamics play out and allowing people in a group to learn from each other, where you're just there kind of as a guide, kind of pulling out themes. It's very different than individual therapy, where you know you're sitting with one person. There might be a specific goal. There's, I mean, depending on your orientation, you know, you're reviewing handouts. Being able to see patients learn from each other, I think, again, it's back to that kind of intrinsic value. It's much more valuable to me,
Right.
and I enjoy being part of that process versus kind of being in that one-on-one.
That makes sense.
Mm-hmm.
They are very different.
Mm-hmm.
Okay, I'm gonna try to be more selective and choosy with these questions
Okay.
because I'm gonna have to wrap it up. So
Go to a part
I'm-
3.
yeah, we're not gonna make a part 3. So you just reminded me when you said depending on your orientation. So we just covered in class what the textbook chapter calls models of abnormality, essentially theoretical orientations, and we covered, you know, biological models, psychodynamic, CBT, humanistic, existential, and then I sort of was teaching them add-on kind of perspectives like sociocultural and family systems and biopsychosocial are less standalone orientations and
Right.
more like something you integrate into an orientation. So one of the questions that I'm sure is front of mind, right, was which theoretical orientation do you subscribe to and why?
Right. Did you talk about integrative?
I didn't.
Oh, okay.
No.
So I would identify myself.
I mentioned my bias against the word eclectic.
Oh yes, I have a bias against that too.
But I didn't talk about integrative specifically.
Yeah. So I mean, ultimately, I would say I'm integrative, meaning that I integrate a lot of different tools to treat individuals. But when we're talking about how I conceptualize someone, I use a cognitive behavioral theory, specifically Aaron and Judith Beck and their CBT orientation. And so when I'm sitting in the room with someone, when I'm assessing them, even as when I'm doing a conceptualization in my assessment reports, the things that kind of pop into my head as people are talking is, okay, what are these, you know, what development did they have that led them to have some beliefs about themselves? So, you know, these feelings of worthlessness or feelings of unlovability or hopelessness, you know, as people are talking, these kind of belief systems are popping into my head. You know, and what rules did these people make about the world to navigate the world, about themselves, about others, about the world, and, you know, how is that popping into their lives constantly? So that's kind of how I conceptualize, taking in kind of what's caused it and then what's maintaining it, what's reinforcing this pattern of thinking and behaviors as well.
Awesome. There was another more specific question, but I think it's one that you will find interesting, you know, with your forensic background, that I have some students who are criminal justice majors, not psych majors, but who are taking psychology courses or like minor in psych. And so one of the questions was about how this, you know, how psychology and these sorts of courses like abnormal will help that person if they're pursuing like a criminal justice field or law enforcement as a career. Yeah.
Hugely. I mean, I'm definitely biased, clearly, but I think that having an understanding of psychopathology, of psychology in general, is so huge in the criminal justice system, because that right now our criminal justice system is our biggest mental health provider. And also, I know both here in Maryland and I was really active in Oregon in my doctorate program. You'll have psychologists go and do crisis intervention training for police officers and how to de-escalate individuals who have major mental illness, because oftentimes their first point of contact is with the criminal justice system.
Right, and a person may not even know what's happening to them. Right?
Exactly.
That's what we talk about like first episode. Mental illness experiences, and then cops are involved, and if somebody in law enforcement has the ability to identify that maybe that's what this is,
yes,
the outcome could be so different.
Hugely different. And learning how to talk and how to de-escalate and understanding what's happening. I just think that is such a huge point. And I think something that we as psychologists can really kind of keep pushing forward and educating. And so people who are going into criminal justice that are getting some psychology training, I think is so valuable and encouraging.
Thank you. The flip side of this question, which wasn't asked, but made me think of it, is, hey, psychology people, you getting some criminal justice is a great idea as well, because that's going to be likely something you will encounter regardless of setting. You're going to get questions about if you will take court-ordered people. You're going to work with people who have who have criminal histories, even if it's not a current question. Like it's very relevant. Okay, I'm trying to narrow down and choose. You're welcome to look as well if you think there are ones. I'm down at the bottom on the second page. Well, maybe you could speak about this one because it's always a question. So there was a question about if you've ever assisted a friend or family member for fun and why you would or would not do such a thing. So you have all this powerful, information and expertise, and probably, family members who you wonder about or have suspicions about. We talked about at the beginning of the semester, I had students kind of rate anonymously if they had family members or friends who were affected by depressive disorders, anxiety, and it seemed really clear that nearly all of us do, right? Whether it's diagnosed or not. So how does that kind of information that you have and your ability to detect, right, these illnesses play in with your people in your life?
As tempting as it may be to want to do this, unfortunately, there's a lot of ethical and legal issues related to that. So I know when I was a student getting trained, we would practice administering tests, but you weren't allowed to score these tests or do anything like that. There's a lot of, I won't go into detail, test security pieces to all of that as well. But no, as much as I would, it's, like that brain can pop up sometimes. We're just not allowed to do that. So no, I've not tested someone for fun.
Unless it was part of your learning and you were specifically instructed.
Yes.
Got it. Agree. Same here, but I can understand why. And then that also gives you a nice out if you, go this path that Dr. Mowrer and I have gone, that you can make it clear to your friends and family that as much as they would like some free, testing and treatment, you can't. You just can't. So that makes it nice and clear too. All right, I'm gonna move towards wrapping up. I'm gonna ask this question. It's very specific, but since I think you encounter this in the hospital, there's someone who's interested in art therapy, and there's art and music therapists that you've encountered, probably in the hospital and other settings. But thoughts on, education trajectory for that person, master's degree versus a doctoral degree?
What I've seen, so I'm by no means an expert in art therapy or music therapy, but what I've seen in the places that I've worked at is most people have a master's degree. More generally, I can say if your focus is really to do therapy, you can do that with either or. But thinking about financial reasons, time, things like that, I know many art therapists and music therapists who have a master's degree who are happy and successful.
Doing very well. Yeah. And we'll take that as like your personal opinion. I always say to students, I offer one perspective, and you should seek as many as you need to, and do your own research and just kind of.
And I definitely recommend trying to connect with an art therapist, because they would be able to provide even better information than I would, because I don't have that specific area of expertise.
Agree.
Yeah.
All right. Any books that you recommend for someone wanting to learn more about your field?
Yes, I wrote these down because.
Okay, good. I'm glad I asked this one, and I can make a list online too.
Well, and I think there's a lot of textbooks kind of that can like lay out different things about psychopathology, but what I've known in my training and things that have really helped me develop empathy, better understand clinical psychology, psychopathology are memoirs from individuals. And so those are, I will kind of talk about some more academic or theory type ones, but I really like some of the memoirs. So ones that came into mind is The Sinner Cannot Hold by Ellen Sachs.
I sometimes use her TED Talk in class.
And many of these people also have TED Talks, so I would recommend that as well. The Quiet Room, so that's Laurie Schiller and Amanda Bennett, and An Unquiet Mind by Kay Redfield Jamison.
It's like my most favorite.
Yes.
Yeah. I think I read that as an undergrad too, and so highly recommend.
And so they're things that are interesting, but also give you a really good insight into what it is like to live and navigate in a world with mental illness. As far as more academia or theory driven, I'm a big Brene Brown fan, as Dr. Norwood knows. So I would say any of her works I think have been really valuable to me.
She has a Netflix thing
does.
too, like
And
a 1
a lot of
hour.
TED Talks.
Did you watch that?
I haven't.
I've read a lot of her books and TED Talks, but I haven't seen her Netflix special. So, but if you want to consume it that way, I recommend, any media that you can consume with Brene Brown is probably worth your time.
And the last person is someone that I just started reading his book. It's called Let's Get Real, and this is by Lee Min-hwa. And so he is an expert in the field of culture and diversity training. So I think that is a huge piece that is up and coming, and I'm really encouraged that we're learning this more as in undergrad, because I didn't get a lot of this training until grad school. And so I just wanted to put that on the list as well.
Right. One thing that I think has been true across all the settings I've worked in, and I imagine same for you, is that you're going to work with a lot of people who are different from you in a number of ways, in how they look, in their life experiences, in language, in religion. And then the flip side of that is that we often encounter patients who look a lot like us, who are nothing like us, right? And so you can draw really unfounded conclusions that you might understand someone based on some superficial qualities. And so it's good to kind of be more thoughtful, right, about diversity and in a number of ways, right?
Exactly.
So, all right, I think that we did a pretty good job covering it. So, Dr. Mowrer, thank you. If students have follow-up questions or want to contact you, would you be open to that?
Absolutely.
Okay, she's the best. So, all right, we're done.
Yay.
We did it.